Welcome back to Forgotten Infection Friday. So today we're going to discuss mysterious infection, a very rare one, and everybody knows I like to talk about neck fast because I don't want anybody to miss it, but I don't want anybody to miss anything, right? Any infection. But this infection actually can leave massive ulcers, severe disability, permanent deformity while the patient delays seeking care because they simply do not feel it or it doesn't hurt as much as it should. And the infection is called a Buruli ulcer, and it's spelled Buruli, Buruli ulcer. And at first glance, a Buruli ulcer may seem like a disease that has little relevance to diabetic foot care and diabetic foot ulcers, but it primarily is found in tropical and subtropical regions, right? And it's caused by a rare environmental mycobacterium. But the thing that this ulcer teaches us some profound lessons that has some parallels with diabetic foot ulcers. It's a painless wound. It has delayed diagnosis, has tissue destruction, immune dysfunction, chronic inflammation, and sometimes patients do need limb salvage intervention. Okay. And in many ways, it mirrors the same biological challenges that we face every day with diabetic foot ulcers. So, as everybody knows, I like to go a little bit about the history of it. So, the discovery of the Buruli ulcer. So, the story begins in Africa. So, although this disease existed for centuries, the first detailed medical description emerged during the late 19th to early 20th century. And in 1897, British physician named Sir Albert Cook documented these unusual skin ulcers in Uganda. And at the time, nobody knew what caused them. The wounds were enormous. The patients developed these painless nodules, plaques, swellings, and weeks later, the lesions broke down into these large ulcers. And the ulcers seemed quite bizarre. They were often deep, extensive, undermined, and surprisingly painless. So it sounds familiar, right? Painless. And doctors initially suspected possible syphilis, tropical ulcers, leprosy, or tuberculosis, and none of them fit perfectly into it. And this mystery persisted for decades. So why is it called a Buruli ulcer? So this disease received its modern name during the 1960s. So you can see that's still very recent, right? So researchers had noticed an unusually high number of cases in the Buruli County region of Uganda, and the name stuck. And ironically, the disease is found in numerous countries, including Australia, Ghana, Benin, and Nigeria, Cameroon, and many other regions throughout the West Africa. And today, Australia has become one of the major research centers studying Buruli ulcers. So who's the culprit? Who is the organism that is responsible for a Buruli ulcer? So the organism responsible for it is Mycobacterium ulcerans, and it belongs to the same family of tuberculosis and leprosy. And however, the Buruli ulcer behaves quite differently because most Mycobacterium diseases causes inflammation, right? And we know diabetes has high inflammation, right? But Buruli ulcer is quite different in that aspect because it suppresses inflammation, and that changes everything. So, the true villain isn't just the bacterium itself, but the toxin that comes from the bacteria. So the toxin is called mycolactone. Mycolactone. And many infectious diseases damages tissue through inflammation, okay? Because that happens with our diabetic foot ulcers. But with Buruli ulcers, it damages tissue by poisoning it. So the mycolactone kills the skin cells, kills the fibroblasts, kills fat cells, kills immune cells, damages nerves, and suppresses the immune signaling. And think about it this way: the toxins simultaneously destroys the tissue, silences the immune system, and reduces pain. And that's a quite terrifying combination. And the secret weapon is mycolactone, okay? That's the secret weapon for this bacterium that Mycobacterium ulcerans, okay? So the normal response to infection, right? When a bacteria enters tissue, your immune cells recognize the invader, the cytokines are released, the blood vessels dilate, the white blood cells flood the area, the pain receptors activate, and redness, heat, and swelling and pain develops. And this is a classic inflammatory response. In most diabetic foot ulcers, we still see some versions of this, right? But with the Buruli ulcer, it does it differently. Instead of the fighting the immune system directly, the mycolactone essentially cuts the communication wires, okay? It's like kinda hits for the jugular. It cuts the communication wire. So the immune cells are present, but they cannot effectively signal for help. The toxin, the mycolactone, targets a cellular structure called the SEC61 translocone. And this protein acts like a doorway through which newly manufactured proteins leave the cell. And the mycolactone blocks SEC61. And when it blocks SEC61, the cytokines cannot be properly exported. The immune signaling proteins become trapped and the inflammatory communication collapse. And pretty much it mutes the immune system partially, okay? Now, like I said, the cytokines get suppressed. So mycolactone reduces production and release of important inflammatory mediators such as tumor necrosis factors, so TNF alpha, IL-2, interleukin-2, interferon gamma, and other pro-inflammatory cytokines. And these molecules normally recruit immune cells to help battle the infection, but the mycolactone suppresses them. So without them, the immune system cannot coordinate properly to break down and fight this infection. Another thing is it affects the macrophages. So macrophages are like the garbage collectors and the soldiers of wound healing. Normally, they detect the bacteria, they engulf the bacteria, they release the inflammatory signals, they coordinate the repair. But the toxin from the Mycobacterium ulcerin, the mycolactone toxin, interferes with the macrophage function, and many macrophages undergo programmed cell death, aka apoptosis. And then other ones just become ineffective, and the bacterial colony gains a significant advantage. Another thing is that T cells are very crucial for controlling Mycobacterium infections. And the mycolactone suppresses the T cell activation, reduces T cell proliferation, as well as weakens the adaptive immunity. So the body pretty much struggles to mount an effective long term response against this infection. And then also, they have little redness. So, redness comes from increased blood flow driven by our inflammatory mediators. So, if the cytokine signaling is suppressed by the mycolactone, there is less vasodilation that occurs, there's a less immune recruitment that occurs, and less visible inflammation that develops. And this is why the Buruli ulcer looks surprisingly quiet. And like I said, it causes very little pain. So mycolactone affects the nerves. So research has suggested that it hyperpolarizes the neurons and reduces nerve firing as well as alter the pain transmission pathways. And as a result, the tissues can be destroyed and the brain receives fewer danger signals and the patient feels far less pain than expected. So that sounds quite familiar, right, with our diabetic neuropathy. So one of the most fascinating aspects of that disease, like I said, is it doesn't hurt as much or the few very less pain though it doesn't correlate with the severity of the wound. So patients may have ulcers measuring several inches across, yet they report surprisingly little pain. Why? Because like I said, the mycolactone interferes with the nerve signaling, the pain transmission becomes impaired, the tissue destruction continues, the alarm system is muted, and we know how that goes. A lot of delayed recognition, right? So why am I discussing this on diabetic foot files? Because Buruli ulcer and diabetic foot ulcer share a very common clinical problem. The wound is worse when the wound is worse than what the patient realizes because of the delay of pain and less pain. Okay, because like I said, in diabetic neuropathy, we have the hyperglycemia that is damaging the nerves. The patient's protective sensation is usually impaired or declined or completely absent, and trauma goes unnoticed. But with the Buruli ulcer, the toxin from that Mycobacterium ulcerin, the mycolactone toxin, damages the nerve function, the pain signals are decreased, and the tissue destruction progresses silently. So that's very, very similar what happens a lot of times with our patients with diabetic foot ulcers. The tissue destruction progresses silently until, the patient fully notices visually, right? And these are different mechanisms, but the result is pretty much the same. Delayed presentation, delayed treatment, and greater tissue loss. So, how does the infection actually begin? Nobody actually knows the complete story because it's rare enough. But current theories include contact with contaminated wetlands, insect transmission, environmental exposure, minor skin trauma. The bacterium enters a break in the skin. Essentially, there is a bump, a nodule, a plaque, or local swelling. Nothing dramatic. No one suspects what comes next. So we're going to go a little bit about the evolution of the ulcer. Like I said, stage one is a small nodule. It starts as a small, painless lump that develops and looks harmless. Stage two is expansion within the subcutaneous tissue. The lump expands sideways. The tissue destruction occurs underneath, and the skin surface remains intact. Stage three, there is massive tissue necrosis. Along the fat and connective tissues begin to die, and the skin appears relatively normal, while underneath the skin, there is biologically a sinkhole forming underneath. Okay. Stage four, the skin finally breaks down. The tissue supporting the skin disappears. The roof can no longer hold because the skin underneath is like a sinkhole. Okay. Because it has this deep destruction of tissue, the deep tissue, like the fat and connective tissue. Okay. And stage 5, there is develops a large undermined ulcer, okay? Because the skin ruptures, the ulcer opens. That is actually one of the key characteristics as well as the ulcer is undermining, significant undermining. And at this point, the patient finally seeks help, but much of the damage has already occurred, okay? Clinicians often describe the edges as undermined, meaning that the tissue destruction extends beneath the apparent normal skin, and the visible wound may represent only a fraction of the actual damage that's happening. Sounds very familiar. We often see this very similar hidden destruction beneath our diabetic ulcers. So, how does the mycolactone, that toxin from the bacterium, kill the tissue? So, first, the local colonization. So, the bacteria enters the tissue, they begin to multiply slowly. Unlike aggressive infections like necrotizing fasciitis, this growth, the mycolactone growth, Mycobacterium ulcerin growth is gradual. Like I said, the patient literally notices. And then the toxin gets released. As the bacteria numbers increases, the mycolactone production increases, and the toxin spreads throughout the tissue and causes the real damage. Then it causes fibroblast destruction. So fibroblasts, we already know, they are such a big foundation for our healing. Fibroblasts are our wound healing cells. They produce the collagen, the extracellular matrix, the structural support, and the mycolactone, surprisingly, kills the fibroblasts. So the tissue that loses its repair crew, and then the wound becomes incapable of normal healing. Another thing that happens, like I said, fat cell death. So the subcutaneous layer contains the I say adipocytes, okay, the fat cells, okay, and the mycolactone triggers cell death, and the fat begins dissolving, necrosis develops, and the tunnels form beneath the skin. Now, blood vessel injury. So small blood vessels become dysfunctional, oxygen delivery fails, nutrient delivery falls, local ischemia develops, tissue starvation begins, and now tissue destruction accelerates. Now, like I said, one of the key things that happen is the suppression of the immune system. So the toxin suppresses the immune signaling. Immune cells struggle to communicate, the inflammatory cytokines decline, and the alarm system is muted. Like I said, it doesn't have the normal warning signs, which is like redness, swelling, heat, pain. The Buruli ulcer suppresses these warning signs. So how does it exactly look? So classic findings of the Buruli ulcer is a large ulcer, necrotic base, undermined borders, minimal pain, minimal redness, minimal fever. The lack of inflammation is quite misleading, and clinicians expect severe infections to look angry, but the Buruli ulcer I mean, that's quite deadly, kinda like a little psychopathic ulcer, right? It acts like nothing's happening at first while it's, like, destroying underneath, right? Because a lot of people don't know who's a psychopath or not, right? Because they act so calm and normal, and so the Buruli ulcer sounds like a little bit of a psychopathic ulcer that, it doesn't cooperate, acts calm, like I said, acts calm because it lacks inflammation, which is often misleading. So, how do we diagnose the Buruli ulcer? Historically, diagnosis is quite difficult, but there are several methods that do exist to test for a Buruli ulcer. PCR testing is the gold standard because the PCR detects the bacterial DNA. Advantages of that is that it's fast, it's sensitive, and it's specific. Biopsy, tissue biopsy will reveal necrosis, clusters of acid fats, bacilli, and a characteristic pathology. Underneath the microscope, they have special stains that can help identify the organism, the Mycobacterium ulcerans. Cultures are possible, but quite difficult because remember the growth of the bacterium is slow, so results may take weeks. And then when it comes to histopathology, pathologists often find that there is extensive fat necrosis, collagen destruction, minimal inflammation, and mycobacterial organisms. So the lack of inflammation response is quite striking to distinguish it, and normal infection triggers the army. So here's that immune system appears strangely absent, or like we say, mute, and the toxin is suppressing the pretty much the soldiers. So how do we treat that? Historically, surgery was primary treatment for a Buruli ulcer. Today, antibiotics play a huge role. Common regimens do include rifampin or clarithromycin, and treatments include are for about weeks. Okay, I would just make sure I get infectious disease on that. Okay, because they know. And large wounds may require debridement, may require the reconstruction, skin grafting, rehabilitation, but what happens if this is missed? The consequences are quite devastating. The patients may develop these massive ulcers, contraction, bony involvement, functional impairment, and disability. Some may require extensive reconstruction procedures, and the tragedy is that many of these outcomes are preventable with early recognition. But like I said, it sounds like the ulcer is a little psychopathic. It remains calm. It says nothing's wrong. It's slow growing. It plays the waiting game. Yeah. So it's kind of a dangerous ulcer. So what lessons can we learn from this also when it comes to diabetic foot care? That pain, I mean, we all need pain so that we can be able to in, understand the severity of certain things, right? Because a lot of people who have protective sensation, like even me, I know something's wrong with my foot or my toe or anywhere because I feel it. Okay, our patients feel the heel pain, right? Especially when podiatry isn't like they look at their heel and like, oh, it looks inflamed, right? They feel it. But with diabetic neuropathy, right? A lot of patients they do not feel it, so pain is not a reliable indicator of the severity of the wound. And with Buruli ulcer, the same thing is happening. Pain is not a reliable indicator of the severity of the infection and the wound. So the wound can be deep, infected, progressive, and even limb threatening while producing surprisingly little discomfort. And that is the same trap that we see what happens with our patients with diabetic neuropathy. The patients often tell us it doesn't hurt, so I didn't think it was that serious. So Buruli ulcers demonstrate how dangerous that assumption is. And don't ever assume that, okay? Just because it doesn't hurt doesn't mean it's serious. That's what I was thinking about why certain patients were getting discharged with clearly gas in their foot, like full blown gas on the whole half of your foot. And I was like, oh wow, like this is what I thought. The light bulb went in my head. They're taking advantage of the patient's diabetic neuropathy because the patient cannot feel and their foot looks completely necrotic, rotten, everything. They discharge them because they do not feel the pain. I'll never forget the patient. It was full blown glass, like gas. Foot foot looked like a balloon, the necrotic bubbles underneath, and got discharged. He's like, "They told me I'm good to go, discharged." He discharged me with some antibiotics, told me to follow up with find a doctor, and I was just so shocked, and I was like, "This is happening too often," and I was like, "It's because they're taking advantage of the patient's diabetic neuropathy." The and the fact of the matter is, a lot of these patients, I mean, power in education, but they trust what their doctor is saying a lot of times, especially in developing countries. They don't have the certain resources, and they do trust what the doctor is saying, a lot of patients. So if the doctor say, "Oh, it's fine. How's your pain?" and everything like that, yeah, but the patient has diabetic neuropathy. The diabetic neuropathy is masking the severity of the infection, even though you can clearly see with your own eyes that this is a necrotic brewing infection, okay? See the difference between the Buruli ulcer and the diabetic foot ulcer? The diabetic foot ulcer is going to blow up, okay? That infection is going to blow up. But Buruli ulcer is suppresses inflammation. But like I said, you the things that I saw that were getting discharged was incredibly crazy and negligent. But like I said, it was a taking advantage of the patient's diabetic neuropathy because the patient wasn't feeling pain. Okay, and the patient wouldn't know because a lot of times I noticed also it was the first time the patient having an ulcer, and so the patient was just like, "Yeah, they told me I was fine." The patient doesn't feel anything. I'm able to cut through that area without anesthesia. Okay, I'm like, "Do you feel this?" Because sometimes it's very important, and you have to understand in developing country it is very resource limited. I'm like, "Where's the lidocaine?" But you have to open it up. You have to open it up, okay, to save th so the tissue could stop progressing, tissue destruction. But like I said, it was people taking advantage of the patient's diabetic neuropathy because the patients did not feel pain. So I want diabetic patients to understand pain is not a reliable source, especially when it comes to you. Take, you know, treat every diabetic ulcer like it's severe, okay? Never just, push it aside and say because it doesn't hurt or because it's small, it is nothing. No, you have that disadvantage of not having protective sensation. It's called protective sensation for a reason because it protects you from allowing there being a greater severity of whatever's going on, right? Because you feel the pain, okay? Pain tells us something is wrong. But when your pain signals are suppressed or compromised, neuropathy or numbed down, you do not know and do not feel it. We have been brought up in this world to use pain as a big indicator of what's going around us, even emotional pain. So we have to really understand that indicator of severity is taken away from our patients, especially who have diabetic foot ulcers and diabetic foot neuropathy. Okay. So that's a great lesson that we learned from the Buruli ulcer. And that another bigger lesson is that every chronic wound exists within its own ecosystem. It has its own microbes, immune cells, fibroblasts, nerves, blood vessels, inflammatory mediators, and the Buruli ulcer shows us what happens when a pathogen learns how to manipulate the ecosystem. I'm telling you, the Buruli ulcer is a psychopath. It's a psychopathic ulcer. It learned how to manipulate the ecosystem of that person's body and the wound. So instead of fighting the immune system silently, directly, it silences it. Instead of causing pain, it suppresses it. Instead of creating an obvious warning signs like redness, swelling, it hides in plain sight. So that makes the Buruli ulcer one of quite a fascinating example of wound pathogen interaction in all medicine. So we have to also really remember that. But for now, I'm gonna now keep on calling the Buruli ulcer a psychopathic ulcer. Okay, the silent but deadly one, right? And like I said, the Buruli ulcer, the mycolactone silences the immune system alarm system and the nervous system alarm system. And in both cases, the wound becomes larger before anybody realizes how serious it is. And that's why the Buruli ulcer is a credible model for us to understand a fundamental principle in wound care. Severity of tissue destruction can occur when the biological warning signs have failed. Okay, so the difference between this is that diabetic neuropathy develops over years from hyperglycemia, whereas the Buruli ulcer creates a similar clinical picture through a bacterial toxin, aka the mycolactone, that actively suppresses the immune system and pain while causing tissue destruction that continue to progress underneath the skin. And this makes the Buruli ulcer one of the clearest examples in medicine of how a pathogen, like I said, can manipulate the wound environment in order to favor its own survival. And I hope everybody loved this episode of Forgotten Infection Friday. This is Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.